Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I am with Doug. How you doing, Doug?
I'm doing great, Dennis. Thanks for having me on.
Outstanding. Today, what I'd like to talk about is some ventilatory management, like the basics. I think, going over the things that the other podcasts that we have done, which I think have been really good, but I think we're kind of missing some of the guys who are just wondering, like, what the frick are you talking about? So if we could kind of start with that kind of framework, and start explaining some of the basic terms and how to get things started. That'd be awesome.
Awesome. Well, thanks again. We'll start off by saying that a lot of people it's easy to confuse ventilator management with airway management because they're all kind of part of the same continuum. But it is important to understand that we put definitive airways in people either by intubation or criking them for one of two reasons, and they're very different reasons. The first is that they need an airway. They've got swelling, they've got trauma, they're not able to clear their secretions, and you need to put an airway in to open their airway. The second reason people need a definitive airway is because they need a ventilator, and the only way to apply a ventilator to a patient is through a definitive airway. But it's important to realize that there are these two reasons, and they're very different physiologies. And people who need an airway many times do not need a ventilator. They could be unconnected from the ventilator or even supplemental oxygen as long as their airway is stented open. But people who need a ventilator absolutely always need an airway. People need a ventilator because they have respiratory failure, because they have a problem in their lungs that either getting enough oxygen in, getting enough carbon dioxide out, or a combination of the two that they can't manage on their own, or with what we call non-invasive respiratory support, like oxygen by nasal cannula or by face mask. And so in this case, then they need a ventilator. And that's kind of what we're going to talk about today is what does it look like when somebody is in respiratory failure, and how do we manage a ventilator once we make the decision to take the airway and put them on a ventilator. I will say that it's an important caveat to understand that lung function is a combination of both ventilation, which is the exchange of oxygen and carbon dioxide in the alveoli, and perfusion, which is the blood supply in pulmonary capillaries to and from the alveoli. And understand that ventilator management, putting somebody on a ventilator can help with ventilation. It can help with gas exchange at the alveolar level, but it can't help that much with perfusion. And we have seen this managing some of our really challenging respiratory failure in COVID, where at least a good part of the problem of their hypoxia is a perfusion problem. And we could get into some of the mechanisms that can help improve perfusion if the ventilator isn't giving them enough oxygen at the end of the podcast, if we have time.
Sure. Just real quick, when we're talking about gas exchange and things like that, is there kind of a go by as far as SpO2s below this? You probably need some sort of vent management, or end tidal above this or below this. Are they kind of like hard numbers, like a GCS less than 8 type thing, or is it more of a trend? Like we've done these interventions and they've not gotten better regardless of the number.
Right. Great question. And I'll give you kind of two answers. Obviously, it's easy when we can say that below this number, we have to do something. We're going to do something. And but we're above this number for carbon dioxide, we're going to do this number. Just like it's easy to say that, GCS less than 8, we're going to intubate. However, life is a lot more complicated, and critical illness is a lot more complicated. And, sort of the best thing for the patient is really to react to trends. Otherwise, we would either intubate a lot of people that don't need it, or not intubate and put on ventilators some people that needed it, where their numbers are looking good but they're getting worse, and we want to get them stabilized before they become unstable. So I would say, in general, you need ventilator management in a patient with either low oxygen, high carbon dioxide, or both, who appears to be in distress, or has a process that could worsen if you don't get them stabilized early. And distress looks like, high respiratory rate, the use of accessory muscles, so retractions, using your rib muscles, belly breathing, any of those is distress. Low oxygen, I think anytime you get below 90%, you should be concerned. Anything below the mid 80s, I think you should be very concerned. That much said, I've seen people with oxygen saturations of 85, 86 who are stable and mentating and not getting worse. And sometimes I'll sit on them. I think of, maybe the elderly patient who, for whom intubation, really wouldn't be a very nice thing to do if that's not really their wish. And, they've got some fluid in their lungs from heart failure, and I know it'll get better if I give them diuretic. I might let them be comfortable as long as they're mentating and not breathing hard, in the mid 80s, as long as it's getting better. But I'm going to be very vigilant. Usually the lower it gets, the more vigilant I'm getting and looking for signs of distress. High carbon dioxide, like a high end tidal CO2, anything in the 50s is probably concerning. Hypercapnia or elevated carbon dioxide will generally not make people as distressed as it will make them sleepy and less responsive, more lethargic. So at really high levels of CO2, end tidal CO2, 70s, 80s, 90s, which we see sometimes in bad, COPDers and et cetera, they'll just be unresponsive. And you'll check a gas or an end tidal CO2 and be like, oh, we need to intubate them. So, like I said, the things to watch out for are they in obvious respiratory distress now, in which case, you need to get on it and get them stabilized before they go into respiratory arrest, which could lead to cardiac arrest. Do they have low oxygen, high carbon dioxide that is likely to get worse? Those are the criteria.
Okay.
Is that clear as mud?
No, that does make sense. And it just goes to just paying attention to your patient. Doing your assessments, kind of coming up with your diagnoses is what is the actual life threat.
Right.
And what is their trend? Are they trending sideways where they're essentially stable and we can kind of hold off going more advanced, or are they trending downward where if you don't get ahead of it, you will never get ahead of it?
Right. Yeah. And just like we talk about mechanism of injury, as far as the risk and trauma of internal injuries and bleeding and hemorrhage, mechanism of injury and illness in respiratory failure is just as important. If the mechanism of respiratory failure is, let's take current events as an example, is COVID, and they're in respiratory distress, they're likely to get worse. And they're likely to get really, really sick and need a lot of ventilator management. So if they're stable now, you really need to keep a close eye on them because they have the potential to get, it's kind of like that blunt force trauma to the steering wheel in a car crash. If they're stable now and their blood pressure is stable now, you still need to keep a really close eye on it because they're likely to bleed from their spleen and drop their blood pressure.
Mm-hmm.
If the mechanism of their respiratory distress is, I thought they were septic and I gave them, every bag of normal saline that I had in my tech set, say 3 or 4 liters of saline, and maybe some volume overload, and I can give them a diuretic and get rid of it, I may not have to intubate them. I might be able to get them through it just by recognizing, that I gave them too much fluid for sepsis or for burn, and that if I back off, accept a lower urine output, and maybe give them a little bit of a diuretic, their lungs might get better.
Mm-hmm.
Does that make sense?
Yeah. Yep. Absolutely.
Right.
Now, so going forward, I think it would be helpful if we kind of went over some common terms when it comes to vent management.
Sure. Got it. So I'm going to go over a few terms because I'll use these when we discuss setting the ventilator and then monitoring and adjusting it for different parameters. So the first term is something called compliance, and compliance refers to the elasticity of the lung, like how easy it is it, how much pressure does it take to open it up and relax. And higher compliance is better. A more compliant lung expands easily, retracts easily. Lower is a sign that it's going to take more pressure to open the lung up and more to open the lung up, which puts it at a higher risk of barotrauma if you're managing it with a ventilator. And also lower compliance is a sign that there's something generally inside the alveoli that's making them less distensible. So, pus from pneumonia, protein, from the breakdown of the alveolar lining in ARDS. So low compliance is concerning both for disease process and because it makes it harder to expand the lung and puts it at higher risk of lung damage. The second term I want to talk about is something called recruitment. And basically recruitment is at least half, if not more than half, of how we improve oxygenation with a ventilator. And what it refers to is the opening up of alveoli that are not participating in gas exchange to get into the game, right? They're collapsed either because of capillary forces, because there's something inside of them kind of sticking the capillary together. Again, edema can do that, blood can do that, pus from pneumonia can do that, protein from ARDS can do that. Or they're collapsed due to atelectasis, just because of gravity, right? The heart lying on the left lower lobe of the lung, a patient who's been immobile in a litter for a prolonged period of time. So generally, it's easier to recruit alveoli that are atelectatic or that have, a higher viscosity of substance in them, right? So water is a very high viscosity, edema. Mm-hmm. So it's fairly easy to pop open an alveoli that's got, pulmonary edema. It's harder to pop open an alveoli that's filled with pus from pneumonia because it's, just think of what pus looks like. It's thicker and more tenacious. So that's recruitment. And the other thing that is important to understand about recruitment is that the recruitment explains why PEEP, positive end expiratory pressure, alone, even on room air, can improve oxygenation. Because, let's say you've got, 500,000 alveoli in both lungs, and 250,000 of them are stuck together for some reason. Well, if you, by applying positive end expiratory pressure, can open up 50,000 of those alveoli, then you have more oxygenation capability, even if you don't provide more supplemental oxygen. Does that make sense?
Oh, yeah, absolutely.
Okay, a couple more, and then we're done. Tidal volume is easy. That's the volume of air entering and exiting the lungs per breath. There's an inhaled tidal volume and an exhaled tidal volume. It's not really important. It just knows that that's basically the volume of every breath. And then a really important concept is something called minute ventilation, which is the volume of air entering and exiting the lungs per minute. And then that's a function of tidal volume, right? Every breath times the number of breaths per minute, which is the respiratory rate. So minute ventilation equals tidal volume times respiratory rate. And you'll hear that term thrown around all the time when you're talking about ventilator setting.
Mm-hmm.
And then the last term I want to talk about is something called ventilation perfusion matching. Remember I said that ventilators can help, with ventilation, getting oxygen in and carbon dioxide out of alveoli. But there's also perfusion, which is blood supply from the pulmonary capillaries. And you basically, in an ideal world, you have every alveoli that's open to exchange gas is supplied with blood from a pulmonary capillary. That's ventilation perfusion matching. And when you get mismatching, that's when you can have some trouble stabilizing your patient that a ventilator may not actually be able to fix. Okay?
Yep, absolutely.
All right. Then the next section that I had really to talk about were, what are the variables on the ventilator that you can set and adjust to help your patient?
Yeah, absolutely. I mean, I think that's probably the hardest part, because from doing scenarios and practicing and et cetera, like I've seen guys, they will just procrastinate and come up with any reason they can think of to not start bagging this person until it's too late, and now you really have to start working on it. So I think if we could just give somebody some comfort as far as, okay, like these are your trigger points. This is when you really need to start thinking about it. This is when you really have to do it. Now it's become an emergency. If we can give somebody, just some kind of framework to start off of.
Yeah, and it's, it is a really tough decision to make, and it's really, I remember when I was a brigade surgeon before I did my critical care fellowship. I was really nervous about taking an airway and putting somebody on a ventilator. I think more really the taking the airway part. Once I had the airway, I think, the ventilator management was easier. Maybe that's because I was medicine trained and, I had worked in ICUs and in residency. But, it's a big deal to, think about, do I need to, sedate this person, paralyze them, put in an airway, which is not an easy procedure and comes with all sorts of potential complications. Or can I get by without it? And I think just practicing, running through scenarios, I don't know if you'll ever be comfortable at it if you're not an anesthesiologist or emergency doc or an intensivist, but, as much as you can think about it and get reps, both in training and for real, is good. And even tabletopping, I think, is good to discuss it.
So how about this? I'll maybe I start off with a scenario, and we
Sure.
kind of free flow from there.
Sure.
So let's say we have a trauma patient coming in. They are in hemorrhagic shock. We have not given blood yet, but we're thinking about taking their airway because of mental status, and we don't want to lose the airway. Gotten drugs on board, life threats as far as hemorrhage control is done, but we're getting ready to start doing a blood transfusions and resuscitation, and their SpO2 is now, it's like it was at 90, now it's at 85, and things look like they're just downward trending.
Okay.
Go.
All right. The first question to ask and answer is is the patient resuscitated? Is their mean arterial pressure or their systolic blood pressure adequate? And
No.
I would say, no. So they're not resuscitated.
No, we are in the
So
process.
Even before you get to ventilator management, then when you're going to do your airway management, you have to be really, really, really careful with the drugs that you choose and the way you intubate this person. Because ideally, we don't sedate a patient for intubation or cric until they're resuscitated. And if we have to manage an airway, take an airway in an under-resuscitated patient, then we need to have a backup plan for managing their blood pressure. And so, first off, your drug selection, I would not use any drug that would drop their blood pressure. So no propofol, no Versed, no etomidate. I know people will say etomidate doesn't drop your blood pressure. I'm here to tell you that it often does, and it always does when you don't want it to.
Right.
And so I would only use ketamine for your sedative, and I would paralyze, with a bolus of probably rocuronium, just so I make sure I get the airway first shot.
Okay. Let's just pretend that. I'm sorry, just a quick add in. Let's just pretend for a second that I don't have any paralytics.
Okay.
So ketamine, 100% agree with. Are you good with cric with just ketamine?
Yeah, 100%. I'm good with that. And I would go back to your sedation and analgesia CPG. I would use 1 to 2 milligrams per kilogram. So easy dose would be 100 to 200 milligrams.
Okay.
And higher, if you don't have a paralytic, higher is probably better.
Yep.
Okay. Now that's the easy part. Believe it or not, drug selection is the easy part. The hard part is not having your backup plan and having people that can implement it for you. So you need to prepare, even with non-sedating drugs, that the actual stimulation of the airway can drop their blood pressure with the vagal maneuver or the vagal response. So you need to be able to support their blood pressure acutely. And in our community, that probably means giving them a bolus of something. And I know that, bleeding patients should get blood, and all hemorrhagic shock should be resuscitated with blood. But in this case, if you don't have enough blood or you can't get it fast enough, you need to support their blood pressure with bolus of fluid. And that needs to be hung in line, ready to squeeze as you're intubating and watching their vitals.
Okay.
Now, ideally, in an ICU, we'll also have push dose pressor support, preferably phenylephrine, and sometimes push dose epinephrine, which is a little harder to dose. But
right.
If you have those drugs and you're familiar with them, I would have them in the room and give a little bit of that and some fluid, just to get your patient through what really is the highest risk of all intubations. Intubating a patient who's in hemorrhagic shock, who's under resuscitated. So there you go. I talked a lot about airway, and we're not even into ventilation of our scenario yet.
But just a quick kind of follow up to that, because I just like to make it perfectly clear. There's a great big difference between a small bump from a push dose pressor and a bag full of it running a drip.
Right.
We're talking about, and correct me if I'm wrong, but I'm willing to sacrifice essentially reducing perfusion because of vasoconstriction with my pressor to keep maintain their MAP, their blood pressure, etc., to keep their heart beating until I can get the tube in and get blood on board to then actually reverse the shock. Is that kind of the thought process?
Right, exactly. And this is all really temporary, right? There's a risk of a vagal response to manipulating the airway that's going to be transient, but it can be profound, and you need to be aware of it. And it's obviously higher risk and more profound in an under-resuscitated patient. So if you're going into taking your airway with a mean arterial pressure of 45, and then you drop that to 35, there's a decent chance you'll put that person into cardiac arrest. If you go into it with a mean arterial pressure of 65, 70, 75, and you drop it to 55, 50, or 45, they could probably ride it out. So
understood.
Obviously, not the main topic of the podcast, but since that's our scenario, I would be remiss if I didn't lead with hey, you got a big risk here. Make sure you manage your procedure and you have a really good backup plan.
Right. No, it's the logistics of it. If you don't understand how to get it done, then you shouldn't be doing it.
Yeah. And I have all my backup plans are always ready when I do a procedure. Like if I go to intubate, there's an IV that's hooked up, the free-flowing IV that's hooked up to a bolus saline bag. There's pressors in the room. There are all my drugs drawn up, and labeled. And obviously I can't do all of that if I'm the operator. So I need to have people that I can, instruct on how to do it. All right. So now we've got them intubated. We got them through the procedure. And it sounds like we're going to be dealing with primarily hypoxic respiratory failure, right?
Yeah.
Okay. So on the ventilator, there are basically 4 things you can control. And I'll start with the things that can control your oxygenation are the supplemental oxygen you provide, which is your FiO2, which, the highest is 100%. And room air is 21%. Then there's your positive end expiratory pressure, or PEEP, which is basically the at the end of the delivered breath, at the end of expiration of the delivered breath, of the ventilator breath, the ventilator exerts some pressure through the circuit, down the tube, into the lungs, above atmospheric pressure, right? And that the idea is that pressure keeps the alveoli from collapsing back together, closed shut, and both makes them easier to oxygenate. It reduces the risk of shear injury from opening and closing alveoli under pressure against capillary forces, and that also exerts pressure that can recruit, remember that term, recruit alveoli that are either collapsed from atelectasis or filled with something. The other 2 variables then affect your removal of carbon dioxide. One of those is the respiratory rate, and the other thing is the volume of each breath, which can either be given as a volume in hundreds of cc's of air, or as a pressure, 5, 10, 15, 20 centimeters of water of pressure. And if you push air in under that pressure, there'll be an associated volume of air that goes in. So, and remember that the respiratory rate and the volume equals your minute ventilation, and minute ventilation is really what controls the removal of carbon dioxide.
Okay.
Okay?
Yep. So just a quick thing, minute ventilation, is that what they're talking about when they say like 6 to 8, cc's per kg? Is that what they're talking about?
Nope, that's actually tidal volume. So
okay.
You set your volume on that. Your minute ventilation is basically, physiologic minute ventilation is measured in liters, not in cc's. Because if you think that you're giving let's say you're a 100 kilogram person at ideal body weight, you're going to do 6 cc's of air per kilogram. That's 600 cc's of volume per breath. If you give 10 breaths a minute, that's 600 cc's times 10. That's 6,000 cc's, or 6 liters. That's your minute ventilation.
Okay.
That's the volume per breath times the number of breaths equals the volume per minute, or the minute ventilation. And so we talk about minute ventilation in liters.
Okay.
That make sense?
It sure does. Is there a common Like an adult male has X number of liters minute ventilation.
No, I mean, it's a function of lung size and fitness. So no, on the low end, it's probably 5 liters. On the high end, it's probably 10 liters,
Okay.
off the top of my
Okay.
head. And we don't really use it to set ventilators that much. We use it troubleshooting sometimes, but again, that's for purposes of setting up the ventilator, what we're really looking at is tidal volume.
Okay.
So, when you're setting the ventilator, the first question to answer is, what is my problem, right? We know that this guy has traumatic injuries. We probably know what his trauma problem is. So now we need to know, what is his lung problem? Is he having, problems clearing CO2? Does he have too much carbon dioxide? Does he have too little oxygen? Or does he have a combination of both? And as you described the scenario, it sounds like he's not getting enough oxygen, and we need to get him oxygenating better. Is that fair?
Yes.
Great. So then, we're going to set up the ventilator to optimize oxygenation with 100% FiO2. And initially, because we don't really know anything about his lungs, and his oxygenation isn't all that bad. I mean, 85% isn't optimal, but it's not terrible. It's not 65%. We can start him at a sort of a normal starting PEEP of 5. And then for ventilation, for removing carbon dioxide, we'll start him at that lung protective tidal volume of 6 cc's per kilogram of ideal body weight. So that's not actual body weight. If you weigh 300 pounds and you should weigh 200 pounds, we don't do 600 cc's times 300. We do 6 cc's, not 600, I'm sorry, 6 cc's times 300. We do 6 cc's times 200.
Mm-hmm.
And then in general, unless you're dealing with hypercarbia, which we're not, set their rate at something physiologic, like 12 to 14 breaths a minute. So, and just always remember with ventilation and respiratory rate that unless you've paralyzed your patients, which I do not advocate, especially without phoning a friend, that patients may well breathe above the respiratory rate set, right? Mm-hmm. So if they're anxious, if they're in pain, if they're acidotic, they're gonna breathe fast to blow off CO2 and try to balance out their acid-base problem.
Right.
So you set a rate, but don't be surprised if the patients breathe above it.
Okay. If I'm using a BVM to start off with, because the Save 2 just scares the crap out of me, is it okay that I don't bag every breath if I'm just trying to assist them ventilating?
I would probably synchronize. Well, it depends how fast they're breathing. Let me take it back. They're breathing 30 times a breath. No, breathe every other breath. Right. If they're breathing something physiologic and it's easy, then I would breathe with them easily. But it really depends, and it also depends on what you're getting. If your end tidal CO2 is 80, and they're breathing 25 times a minute, I'd probably give them a little extra volume, because that volume is going to help them move out CO2.
Right.
As long as you can squeeze that fast without getting carpal tunnel syndrome.
Yeah, that's true. Yeah, absolutely. Because I'm in this patient that we're kind of describing. I would imagine he has what a VQ mismatch, or a ventilation perfusion mismatch. So you're only going to get so far with your initial, let's say your initial blood bag, and vent management. You need to continually resuscitate him until he's out of shock while doing vent management to actually bring him back.
And that's a great point. If people in shock are almost always going to have a ventilation perfusion mismatch, because they just don't have enough volume to perfuse all the pulmonary capillaries. Mm-hmm. Which is why people in shock go into respiratory tests. One of the reasons.
A little bit off topic, but surrounding this. So I'm giving somebody blood. I'm also doing vent management. Mm-hmm. And say, I'm doing vent management and I'm kind of hitting a ceiling with my PEEP. Maybe is it worth doing like some kind of recruiting maneuver where maybe I go up on my PEEP to try and get a little bit more, or do I just focus on sending the blood?
Yeah. I would, let's put aside the term recruitment maneuver for a while, because that's really kind of last ditch.
Sure.
I would, in your under resuscitated patient, I would focus on the resuscitation and accept stable, acceptably low pulse ox.
Okay.
Right. So, we started this guy with a pulse ox of 85%. We've got him on an FiO2 of 100%. We've got him on a PEEP of 5. Let's say his pulse ox fell to 80%. It's perfectly reasonable to go up on your PEEP to 10. If the oxygenation improves, great. If it stays at 80, you may have a perfusion problem that just needs more resuscitation. Part of that is where compliance comes in as well, right?
Right.
So if the lungs are relaxed and low pressure, your peak pressures are low and your plateau pressures are low, which I'll get into, and you give them 10 a PEEP and they're still hypoxic, then it's probably a resuscitation problem. If your compliance is low and your peak pressure is high and your plateau pressure is high because you're straining to get breath into these non-compliant alveoli, then maybe increasing your vent management could help.
Okay.
So it's at least a 3-dimensional problem.
Oh yeah. Yep. Nothing in life is free. So.
Right. But I would feel okay, with people who aren't experienced going up on PEEP to 10 or even 15, as long as their pressures are okay, and we can get into that. I've got a few notes on troubleshooting and monitoring. If they start running into high pressures on the ventilator, then you have to back off. You can't go anymore. You can't apply any more pressure through the ventilator if the pressure readings that you're getting on the ventilator, your pulmonary pressures are high, because you risk damaging the lungs with barotrauma, at least until you phone a friend and have a discussion. So monitoring wise, obviously you're going to monitor oxygenation probably with a pulse ox, or a PaO2 if you can get an ABG, and then you're going to monitor ventilation or removal of carbon dioxide with an end-tidal CO2 or your PCO2 on an ABG. And then the other thing you're going to monitor is you're going to monitor your ventilator, right? And the things that you're mostly going to look at on your ventilator are your peak pressures, or peak inspiratory pressure. Sometimes it's called peak pressure. Sometimes it's called PIP, peak inspiratory pressure. And then all ventilators have a way to measure something called the plateau pressure. The peak pressure is the pressure it takes to initially get that breath of air in, and and that includes resistance through the circuit, right? The ventilator circuit, the endotracheal tube, the tubing, etc. Because you have to overcome that to get the breath in. The plateau pressure is the pressure that it takes to hold the alveoli open, and is supposed to be independent of the circuit. It isn't 100%, but it's more independent of the circuit. So the plateau pressure is a better, not perfect, but better measurement of compliance, of the pressure it takes to open the lungs. And we want to keep our peak pressures under 35 centimeters of water, and our plateau pressures under millimeters of mercury. Centimeters of water. I wrote the units down wrong on my cheat sheet here. 35 centimeters of water for peak, 30 centimeters of water for plateau. Okay.
Okay.
And if they're lower than that, as you're ventilating them, then they probably have good compliance. They have high compliance and fairly elastic lungs. If they're high, then one of two things. happens. Either their lungs are stiff and non-compliant, and low compliance, or if the peak pressure is high, especially, and the plateau is not as high, you may have a problem in the circuit, right? And so things that, because remember, peak pressure is a better measurement of pressures in the circuit as well as the lungs. And so at that point, you want to troubleshoot the circuit, right?
Mm-hmm.
So suction the patient, right? Do you have something obstructing the tube or the airways immediately below the tube? Check your tubing for kinks. If they have an endotracheal tube, are they biting the endotracheal tube? We just had a patient recently who bit her endotracheal tube in half, fortunately, as we were extubating her. So that's a great reason that peak pressures are high.
Right.
If they're biting their tube, you can put in a bite block and you can give them some more sedation, especially if it has to stay in. You can check for bronchospasm. So listen with your stethoscope. Do they sound really wheezy? Not everybody's going to carry albuterol, but if you do and they sound really wheezy and their pressures are high, you can give them some albuterol. And then as a last resort, if their peak pressures are high and you can't find anything, disconnect the vent from the tube, from the crike or the endotracheal tube, and see if the pressure is normalized. If the pressure comes down, you hear a rush of air and pressures come down, then you may be breath stacking, which is, a patient that's really basically breathing so fast that the lungs don't empty out the complete volume and before the next volume is given, and those incremental additions of unexhaled volume add up to cause pressure. So that's really the big troubleshooting that you'll do. When you check a plateau pressure, or if that's high, then there's probably something in the alveoli, and you just need to back off on your settings.
Right. Is that I've been reading about drive pressure, where you take plateau pressure minus your PEEP, and was it trying to get that number to 17 or 15, or less?
Yeah.
Okay. Which one is it, by the way?
I don't know off the top of my head either.
Okay.
Probably fine. But yeah, it's a little bit more modern method of adjusting your pressures. I tend to look at the plateau pressure. If it's under 30, I'm good. I've got room to go up on things that affect my pressure, which is basically everything, right?
Right.
The PEEP will affect your pressure. The volume will affect your pressure in the circuit, in the lung. The rate can, or if you're on pressure control, that will as well. So you have to decide which variable you need to manage. If their PEEP, their plateau pressure is less than 30 and they're still not oxygenating well enough, then I know I have room to go up on my PEEP. If it's less than 30 and they're not ventilating enough, then I know I have room to go up on my tidal volume or my pressure with every breath. And if it's not, then I have to go down on something. Ideally, something, if I have to go down on something, I'm going to go down on something that doesn't affect the variable that I'm trying to treat, right? So if they're hypoxic and their plateau pressure is high, I want to keep the PEEP for the oxygenation, so I'll probably decrease my tidal volume.
Right.
If I'm not having trouble with clearing CO2. And I may accept, an end-tidal CO2 in the 50s just so I can oxygenate the patient at a decent pressure.
Right.
So you can see how, like I said, it definitely gets to be a three-dimensional problem.
Oh, yeah, absolutely. Let's see. Was there anything else there's a lot that we have not covered, but at least for this kind of basics round, is there anything that guys really need to know?
No, really. I'm surprised I got to the end of my cheat sheet or my outline, and we're there right now. So
right.
I think we covered all the basics.
Yeah. Yep, I think so. And we managed to get Airway in there as well, and resuscitation.
And we got Airway in there, and we're under an hour, and dinner will be served in 3 minutes.
Okay. Well, I don't want to keep you from dinner. Hey, Doug. Hey, thank you very much.
Oh, you're welcome, Dennis. This has been fun, and thanks for your good news about the master's program.
Yeah, I'm pretty excited about it.
Yes, be sure to go to our website, www.prolongedfieldcare.org. Find us on Facebook, YouTube, Instagram. Subscribe and stay on the bleeding edge of combat medicine. This is Dennis for the PFC Podcast. Out.
Boy, it's waiting there for you.